Baba. Yeah, I think that we can start. I said that a message has been sent to all those who register for the event. So maybe now we can start with a short introduction and then go on with the webinar. And in the meantime, other persons will join to benefit from the webinar. So, Baba, if you would like to introduce the day or say anything, then I could present the project and team. Baba, now you are on mute.
Yeah. I'm okay. So good afternoon, and welcome to the first webinar that we have on iron overload, an elusive complication in sickle cell disease and thalassaemia. And I mean, there are certain key points, particularly for sickle cell disease, that we wanted to highlight the fact that it is an issue. And we want to highlight the fact that blood transfusion in sickle cell disease, there are a number of different reasons. And this include spontaneous transfusion, or maybe I would say episodic transfusion as a result of severe anemia, and which can come and go. And a very high proportion of patients, maybe 1 in 2 patients, would have had one of blood transfusion probably before the age of 20, particularly those with sickle cell anemia. And but actually others could have more repeated transfusions, and this could be recorded, this could be unrecorded, and therefore the question is, when do we begin to think about iron overload? And we know that I mean, again, Tim would be discussing all the details in terms of iron in terms of its movement, in terms of excretion and everything. He's going to go through that. So we think it is a good opportunity for us to have a discussion, because ARISE gives us a platform to interact. Next slide. And so we're just talking about ARISE. Duccio, are you moving the slides? Thank you. Okay, so Duccio is the coordinator, and you are very much aware of Duccio's role and how he has been very key in driving this initiative. Duccio, you can talk about that slide if you want.
Yeah, thank you. So it is just to provide you with a few information about the RISE, which is an European Commission funded project starting in 2019, and whose activities are spreading through 5 main domains, each well interconnected with the others, and with 2 main aims. The first one is to have a universal newborn screening program implemented and embedded within regional and national policies in sub-Saharan countries, which is the main target for the RISE actions, and to build capacity of personnel in the same countries, so to achieve excellence in clinical practice and research, using sickle cell disease as a kind of learning, living laboratory for the improvement of personnel. As any other project, ARISE is built on a complex work program made of several actions, tasks, but the main output, what we are achieving now through a staff exchange program, is having a number of health professionals improved in a series of topics: implementation science, laboratory skills, epidemiology and statistics, clinical management of sickle cell, genetic counseling, TCD, research, and dissemination and communication. Everything is built around the burden of sickle cell disease in those countries where it is endemic. And we have put together 19 different institutions plus several affiliated. So it is a very large family based and connecting European countries with African countries and the US. When people moving from one country to another to connect and link, so in a larger family, so that both early stages and experienced researchers can work together with support from technical administrative staff towards the achievement of the two main goals for the project. We will have, by the end of the project, in 1 year from now, almost 560 exchanges completed. This is the target. And it is currently ongoing. The webinar that we have organized today with the collaboration from Tim, the resonance set company, and the camera consortium is spreading from an action which has been built within one of the work packages in the project, and that is the need to analyze healthcare policies and the organization of centers providing healthcare for sickle cell patients. We have a study, a questionnaire-based study designed at the Kaduna State University with support from project partners, aiming at mapping and analyzing the characteristics of the centers, mainly in terms of accessibility and readiness of health technologies. The technologies we are considering are blood transfusion, MRI, and TCT. The technology, the need to map and describe the availability and the accessibility to technology is to help providing context-related information supporting the adoption of best practices in sickle cell management. To the same, we have developed a series of questionnaires based on the WHO approach, service availability and readiness assessment. So the questionnaire includes several indicators which will be analyzed at the end of the work, providing what we are looking for. The questionnaires have been already piloted in 4 reference centers in Nigeria who volunteered for participating in this action. And in the second phase, as soon as we obtain all the ethical clearance, we'll see all those reference persons participating in the project or linked to project activities, including all of you who consented to receive information and to be invited in activities, receiving the questionnaire and the invite to complete it or share it with other more appropriate colleagues in the same organization. Then we will move from Nigeria to Angola, Kenya, Zambia, and Lebanon, and to any other African countries willing to participate in this initiative. The first phase is planned to end in summer 2024, next year, so in time for the project completion. And this is the, within this framework, we have found the opportunity to collaborate with Professor Tim St Pierre, who is so kind to work with us and stay with us today for this webinar on the complication of sickle cell disease and thalassaemia, talking about overload, iron overload, and how to monitor iron overload through MRI or other techniques. Some of you may already know Tim. He is a senior honorary research fellow at the University of Western Australia with a part-time position at Resonance Health Analysis Services, which is a company. Well, I think, Tim, that now the floor can be for you. But before that, let me remind everyone that we will have in 2 weeks from now a second webinar on MRI diagnostics. So you have already registered for both. The link to join is the same, and so we will meet again in 2 weeks. So thank you, Tim. It's for you. Thank you.
Okay. Thank you, Duccio. I will now start to share my screen. Can everybody see that?
Yes, thank you.
Oops, let me just go back a bit. So thank you very much, Duccio, and also thank you very much to Baba Unusa for inviting me to give this webinar today. It is a great honor for me to be able to participate in the ARISE initiative. And as Duccio has mentioned, I want to talk about iron overload in sickle cell disease and how we can use magnetic resonance imaging to help us measure the extent of iron overload in sickle cell disease. As the title here suggests, I'm also going to be talking about thalassaemia. And the main reason for that is that so much of what we know about iron overload has been learned from the study of thalassaemia patients. Not all of it is applicable to sickle cell disease, but a large fraction of it is. And that is why we are going to be talking about thalassaemia today as well. Oops. So first of all, before I start the talk, I do have some competing interests to declare. I have a part-time employment with Resonance Health Analysis Services, who are the providers of FerriScan, FerriSmart, and LiverSmart. So who am I? Well, I am a physicist by training, and it's probably worth noting that I am not qualified to diagnose patients or give medical advice to patients. My experience is really as a scientist. I live and work in Australia. As Duccio mentions, I have worked at the University of Western Australia in Perth for about 25 years now. And my research career has focused on measuring the properties and quantities of iron in biological tissues. And I've worked with many medical practitioners on the applications of magnetic resonance imaging, in particular, to the measurement of body iron concentrations. And as such, I have a strong interest in sickle cell disease and thalassaemia. So I thought I would start the talk by describing the metabolism of iron in a healthy individual. Iron enters the body usually through the diet. So we eat food and the food is digested in our stomach, and iron is absorbed into the body through the gut wall at the rate of about 1 to 2 milligrams per day. And that iron is then transported via a protein called transferrin to places like the muscle, where it's used in myoglobin, but mainly to the bone marrow, which is the site of the manufacture of red blood cells. And here the iron is converted into hemoglobin. And the amount of iron in our bodies in the form of hemoglobin is typically around about 1.8 grams. The red cells circulate in our body, and at the end of their lifetime, they are recycled through reticuloendothelial macrophages, where they are broken down and the iron is transported back to the bone marrow by the transferrin, where the cycle starts again. And any excess iron is shunted off to the liver for storage. And typically, a healthy adult will store about 1 gram of iron in the liver, which can be used when iron availability becomes scarce. We also lose iron at around about 1 to 2 milligrams per day. And notice that that's the same sort of quantity as the amount we are absorbing per day. And we lose that iron through desquamation of mucosal cells in the gut, through menstruation or other blood loss. So, some things to note about this healthy iron metabolism. First of all, the healthy human body cannot excrete iron. There is no excretion mechanism. Iron stores, therefore, are controlled by controlling the absorption through the gut. So the way the body works is that we absorb more iron when we are iron deficient, and we absorb less iron when we are iron replete. And we have between 4 and 6 grams of iron in the healthy human adult. So that's healthy iron metabolism. And in this case, most of the iron is in the form of hemoglobin or storage iron in the liver. That's where most of the iron is. Things that can go wrong. First of all, there are genetic factors. So, for example, there can be genetic factors that result in the loss of the control of iron absorption. And these factors would include diseases such as hereditary hemochromatosis. There can be genetic factors that alter the structure of hemoglobin, such as sickle cell disease or thalassaemias. And with these malfunctioning hemoglobins is a resulting disturbance of the usual metabolic balance of iron in the body. And we'll talk a bit more about that later. Another thing that can happen is that iron can bypass the normal absorption mechanism. So, for example, patients who receive blood transfusions receive the iron parenterally, and therefore there is no control over that intake of iron. Similarly, iron infusions bypass the gut absorption mechanism. Infection can also disturb the iron balance. Infections can alter the production of hepcidin, which is a hormone that controls iron absorption. And there are other kinds of infections, such as parasitic infections, which may themselves metabolize iron and disturb the balance. And various other things can go wrong, which I don't have time to talk about today. What's worth mentioning is the special case of sickle cell disease. And it was shown back in the 60s that in sickle cell patients, there is excretion of iron through the urine. And the reason for this is because sickle cell disease is one of the diseases that involves intravascular hemolysis. And so iron that's broken down in the blood vessels can pass to the kidneys and hence out into the urine. And this is quite important and actually distinguishes the type of iron overload that sickle cell patients experience from those in thalassaemia, where the hemolysis is more within the bone marrow. This situation was nicely summarized by Porter and Gabowski in 2013. And they drew up this diagram here that explains the movement of iron around the body. It's similar to the diagrams I've shown before, but is specific for sickle cell disease patients. And in this case, for untransfused sickle cell patients. So as usual, iron is absorbed through the gut and passed to the bone marrow via transferrin, where it's converted. The iron is then put into hemoglobin in the red blood cells that enter the bloodstream. And because of the hemolytic processes in sickle cell disease, as I've mentioned, some of that hemoglobin iron ends up in the kidney and can be excreted in the urine in the form of a type of hemosiderin, which is a type of rust, which I'll come to later as well. So the key thing here is the excretion of iron in the urine. Now, in the diagram below, this is the modification for sickle cell patients when they are transfused. And you'll notice that the size of the arrows is a little bit different from the diagram above. Large arrows mean large movement of iron, smaller arrows mean smaller movement of iron. So in this case, iron is still absorbed from the gut, maybe not at quite the rate it was for the untransfused cases, but critically, iron is entering the body through transfusions. And the red blood cells that are transfused eventually get taken up by the reticuloendothelial system. The iron is transported to the marrow again and built into the hemoglobin of new red blood cells. But because these patients are transfused, the hemolysis is more under control, and therefore there is less iron passing to the kidney and less iron passing out through the urine. So this is something that is unique to sickle cell disease, and possibly also diseases like paroxysmal nocturnal hemoglobinuria. But this is not really experienced in the thalassemias, for example. Now, under normal circumstances, iron atoms in the human body are bound to biomolecules. And what I mean by that is they're bound to proteins, and proteins such as transferrin and ferritin. I've already mentioned transferrin. These are two diagrams of what the molecules transferrin and ferritin look like. They're schematic diagrams. And if we look at transferrin first, this protein can bind up to 2 iron atoms. So it can bind 0, 1, or 2 iron atoms. And this protein acts as the body's iron taxi. There's only about 3 milligrams of iron in the entire body bound to transferrin, but it's constantly dropping off and picking up iron atoms and transporting them from places like the liver, the spleen, to the bone marrow, and so on. Ferritin, on the other hand, can store thousands of iron atoms. Ferritin is a spherical, cage-like protein, and the iron atoms can enter through channels into a cavity in the center of the protein. And as they build up inside that cavity, they form a crystal, a particle of iron oxide or rust. And in this form, the iron is safely stored. In this picture here, you can see an electron microscope image of a thin slice of iron-loaded liver. Now, the liver is the primary storage site of iron in the human body. And in this particular picture, you can see lots of small blobs. Each one of those blobs is actually an iron oxide particle, either in a ferritin molecule or possibly in another form called hemosiderin. But each blob contains around about 3,000 iron atoms. And that is how the iron is stored in our liver. So I've talked about iron being bound to biomolecules. The reason we talk about that is because unbound iron is toxic. And at high concentrations of excess iron in the body, there are not enough biomolecules to safely bind all of the iron. And under these circumstances, a form of iron known as non-transferrin bound iron, or NTBI, is formed and is released into the body, into the bloodstream. And NTBI can spread to other organs, such as the heart and pancreas. And NTBI, being unbound iron, can cause chemical reactions, usually oxidation reactions that damage cells in the liver, the pancreas, and the heart. So, how can we measure the concentration of iron in the liver? we can see that it's important to understand how much iron is there, because as we've seen, if it exceeds certain critical levels, then NTBI starts to be formed. One way to measure the amount of iron in the liver is through liver biopsy. This involves cutting out a piece of the liver and sending that small specimen to a chemistry laboratory for analysis. This, of course, is an invasive procedure and is not suitable for repeated measurements. Alternatively, we can exploit the magnetic properties of iron and measure iron non-invasively using magnetic techniques. And the first technique that was successfully used was a rather specialized technique called superconducting quantum interference device-based magnetic susceptometry. That's a bit of a mouthful, and it has the acronym SQUID. So you may occasionally come across a paper talking about SQUID measurements. This is a way of measuring liver iron concentration that I will briefly talk about in a minute. The other magnetic method that's very commonly used is magnetic resonance imaging. And this is a more useful technique because magnetic resonance imaging scanners are becoming much more available globally. And because these are non-invasive techniques, they are suitable for repeated measurement. Coming back to the biopsy, there are several ways to take a liver biopsy sample, percutaneous, laparoscopic, or transjugular. But there are major complications or risks of complications with biopsy that you can see in this table. And it's because of these complications that biopsy is now rarely used for routine monitoring of liver iron concentration in patients at risk of iron overload. The SQUID technique that I mentioned works like this. I won't go into all of the details, but essentially it involves a device that can do two things. First of all, it can apply a strong magnetic field to the liver. And secondly, it has, in this red box here, a sensor that can sense not only the magnetic field that the device generates, but the enhancement of that magnetic field because of the iron in the liver. And the way the machine works is that while it's switched on, the patient is actually lowered underneath the device so that the liver moves further away from the magnetic field and sensing device. And using some complicated mathematics, by measuring how much the magnetic field in the sensor decreases, the physicists can calculate the concentration of iron in the liver. This is a picture of a volunteer being measured with one of these devices. This picture is actually me several years ago in Turin, in Italy. And as you can see, I'm lying on a special bed that can move downwards so that my liver moves further away from the magnetic sensor device, enabling the physicists to calculate the amount of iron in my liver. Magnetic resonance, well, before I finish, if I just go back to this, the problem with this technology is that there have only been 3 or 4 of these devices ever built, and I think there's only 2 or 3 operational globally at the moment. And this is why we're interested in magnetic resonance imaging, because magnetic resonance imaging is a general imaging technique that is available in many major hospitals around the world today. The way it works is the patient lies in a tube, and there are electric coils around the tube that can apply a very large magnetic field to the patient. The machine can also generate radio signals, which send signals into the body, which is part of the way it makes the images. And importantly, no X-rays are used. So there is no ionizing radiation involved in this technique, which means that it is suitable for repeated use. I thought I'd show you a quick film or movie of a patient being prepared for scanning. You saw there an antenna going on the abdomen of the patient. That's what's done if you're interested in making images of the liver, for example. The patient is moved into the tube where the magnetic field and radio signals are. And then you can see that the operator can then start to generate images of the soft tissue inside the body. So this technology is used for all sorts of different kinds of medical imaging where soft tissue imaging can be useful. What we have been involved with in recent years, is using magnetic resonance imaging to measure the concentration of iron in the liver and in fact in other organs too. But today I'm going to concentrate on the liver because that in many ways is the primary organ of interest, especially with sickle cell disease. So how can we use this to measure iron in the liver? Well, let's go back to that electron microscope picture that I showed you earlier about the form of the iron in the liver. The iron is stored in those small granules of iron oxide. And when the patient is in the strong magnetic field of the scanner, each one of those little particles of iron oxide or rust turns into a small magnet, and it generates its own magnetic field. And what we've been able to do is to develop a way for the magnetic resonance scanner to detect those little magnetic perturbations that are generated by the rust particles. And the technology we were involved in developing is called FerriScan. And what it does is it generates a special type of magnetic resonance image that you can see on the left here. This is an image of an axial cross-section through a patient. And the image of the liver has been specially processed so that the pixels in the image are bright wherever there is a high concentration of these rust particles, and it's dark wherever there's a low concentration. So essentially, this image is a map of the concentration of the iron oxide particles in the liver. And on the right-hand side, you can see a histogram of all the pixels in the liver. So this shows us, this histogram on the right, if you can think of it as a histogram of the variation of concentration of the particles in the liver. So this is what the histogram and the images look like for 4 different patients. The person at the top has a normal liver iron concentration, and the person at the bottom has a very high liver iron concentration, about 25 milligrams of iron per gram dry tissue. And the 2 patients in the middle have intermediate liver iron concentrations. And what you can see is that this histogram shifts to further and further higher values towards the right as the liver iron concentration increases. And so with appropriate calibration, this technique can then be used to measure the concentration of iron in the liver non-invasively. So I'll just, as an aside, I'm going to talk much more about the technical details of that in 2 weeks' time. But for the moment, I want to now ask the question, how can measuring the liver iron concentration be useful in relation to sickle cell disease and thalassaemia? And as I mentioned before, I'm going to talk about thalassaemia because much of the research on iron overload has related to thalassaemia patients, and we're going to use some of what we learn from them to help us understand sickle cell disease too. So in transfusional iron overload, the patients receiving multiple blood transfusions are at risk of iron overload because the iron has bypassed the normal control mechanisms at the gut. And 1 unit of red cells that's delivered gives approximately 200 to 250 milligrams of iron to the body. And because the human body generally has no natural mechanism for excreting iron, the iron levels build up over time. And iron chelation therapy is therefore necessary to prevent iron-related tissue damage. So iron chelators, which is probably a topic for another day, are used to bind iron to enable it to be excreted from the body. Now, with studies on thalassaemia patients, a very important discovery was made by Angelucci and colleagues in 2000, where they showed that the total body iron stores in the entire body are related linearly to the liver iron concentration. The way they showed this was to recruit thalassaemia major patients who had been cured of thalassaemia through bone marrow transplantation. So they were no longer dependent on transfusions. And they could therefore be de-ironed using phlebotomy therapy. So they were de-ironed by removing blood, 1 unit of blood per week over a period of time. And the researchers counted up the total number of units of blood that they took from each patient to reduce their iron stores to normal. And therefore, they could retrospectively calculate the total body iron stores as the sum of all the iron in all of the blood units that were removed from the patient. So that's plotted on the vertical axis here. And then on the horizontal axis, we have the liver iron concentration measured by biopsy. And you'll often hear people talk about the Angelucci equation. This is an equation that, from this graph, that enables you to approximately calculate the total body iron stores in a patient if you know what their liver iron concentration is. Now, serum ferritin is also used to assess body iron stores or liver iron concentration. And the reason that serum ferritin is used is because in a population of patients or averaged over a long period of time, serum ferritin does show a correlation with liver iron concentration, as shown in this graph here from Brittenham and colleagues in 1993. What you can see here is on the vertical axis, the plasma ferritin or serum ferritin, and on the horizontal axis, the liver iron concentration measured by biopsy. And we have data both for sickle cell disease, which are the enclosed or full circles, and for thalassaemia, which are the open circles. And you can see the correlation, but you'll also notice that the scatter on the graph is very large, which means that for an individual patient, measurement of serum ferritin is not a hugely reliable indicator of liver iron concentration. For thalassaemia intermedia, the situation is even worse. On the left, you can see results from a study by Origa and colleagues, where the closed circles show the relationship between serum ferritin and liver iron concentration for thalassaemia major patients, and the open circles are for thalassaemia intermedia patients. So these are non-transfusion dependent patients who still become iron loaded, as you can see, liver iron concentrations right up to 25 milligrams of iron per gram dry tissue, but almost no correlation with serum ferritin whatsoever. So for these patients, serum ferritin is extremely unreliable. And this phenomenon was confirmed, not quite to the same degree, but to some degree by Taher and colleagues in 2008, where in this case, the dark triangles are the thalassaemia intermedia patients, showing a lower correlation with serum ferritin compared with the thalassaemia major patients. And finally, here's another graph showing serum ferritin along the horizontal axis, in this case for sickle cell patients, against liver iron concentration on the vertical axis, this time measured by magnetic resonance imaging. This is a study from Coates and Wood in California. And once again, you can see the extremely large scatter, showing how we must be very careful interpreting serum ferritin measurements in sickle cell disease. Now, let's recap on why it's important to control body iron stores. The free or labile iron, which would include the non-transferrin bound iron that we talked about, causes tissue damage. And tissue iron deposits, those rust particles that I talked about, they are a source of this free iron. The liver is the primary site of iron storage. And if that liver iron storage capacity is exceeded, then iron starts to be deposited in other tissues of the body, including the heart and the pancreas. And iron deposits in the heart are associated with heart failure, especially in thalassaemia. And excess iron in the liver can induce fibrosis and cirrhosis, which are very serious in terms of their implications for liver cancer. Now, for thalassaemia major, the implication of liver iron concentration and prognosis was illustrated in a study by Telfer and colleagues on 32 thalassaemia major patients, all of whom had their liver iron concentration measured by biopsy. And Telfer and colleagues then categorized the patients into three groups, as in this table at the bottom here. Patients with a liver iron concentration less than 7 milligrams of iron per gram dry tissue, that was group 1. Those with liver iron concentration between 7 and 15, that was group 2. And those with liver iron concentration above 15 milligrams of iron per gram dry weight, that was group 3. And on the survival curve here, what we're looking at is the cardiac disease-free survival for the three different groups. And what you can see is that group 3, the group that had liver iron concentration greater than 15 milligrams of iron per gram dry tissue, had much worse cardiac disease-free survival outcomes than those patients with lower liver iron concentrations. Now, in sickle cell disease, it turns out that cardiac iron loading is quite rare. There have been several studies that show that the extrahepatic consequences of iron, particularly endocrine and cardiac effects of iron overload, are lower or more delayed in sickle cell disease than they are in thalassaemia major. However, it should be stated that while it's rare, iron cardiomyopathy is detectable in about 2.5% of chronically transfused sickle cell patients. For patients on episodic transfusion, the rate of iron-induced cardiomyopathy may be even less. So with all these studies, the guidelines have come up with various liver iron concentration thresholds that have clinical relevance. And these thresholds here have been developed primarily from the thalassaemia literature. And if we look at these thresholds, at the top, we've got 1.8 milligrams of iron per gram dry tissue. This is the upper 95% limit of normal liver iron concentration in the healthy population. At the other extreme, at the bottom of the table, is 15 milligrams of iron per gram dry tissue, which is the threshold above which there's greatly increased risk of cardiac disease and early death in patients with transfusional iron overload and thalassaemia. And then in the middle, we have two other values. We've got 3.2 milligrams of iron per gram dry tissue. This traditionally was the phenotypic definition of iron overload in patients with hereditary hemochromatosis. And it became a suggested lower limit for the optimal range of liver iron concentrations for patients on chelation therapy. The logic was that below 3.2 wasn't considered particularly iron overloaded, and that chelating below 3.2 may increase the risk of chelator toxicity. Then this number 7 milligrams of iron per gram dry tissue, was a liver iron concentration above which, in many studies, there were observations of increased iron-induced complications, such as liver fibrosis, for example. And so this window between approximately 3 milligrams and 7 milligrams per gram dry tissue became an optimal window or target for chelation therapy for patients on transfusion therapy. More recently, chelation therapy has become available for non-transfusion dependent thalassaemia patients, where the risks are slightly different. Because non-transfusion dependent thalassaemia patients accumulate iron at a much lower rate, one has to be more careful about chelation. And so in these patients, the threshold of 3 is used as a threshold below which chelation should be stopped for non-transfusion dependent thalassaemia patients. And the liver iron concentration of 5 is the concentration above which iron chelation can resume or start. And there's also in the guidelines, the liver iron concentration of 15 for these patients is used as a threshold above which a higher starting dose for the deferocyrox chelator should be considered. So, summarizing what we've said so far, the measurement of liver iron concentration is important because it's the best measure we have of total body iron stores in the patient. And it gives us information on when to initiate chelation therapy or increase the chelation dose, decrease the chelation dose, change the mode of chelator even, or perhaps cease chelation. But are there any liver iron concentration thresholds specific to sickle cell disease itself? There is not quite so much research in sickle cell disease, but I'll show you what we do have. In 2001, Nancy Olivieri published a paper on the progression of iron overload in sickle cell disease. And she had obtained 42 biopsy specimens from 20 patients with sickle cell disease. They had a mean age of about 16 years, and they had been receiving blood transfusions. And both the liver iron concentration and the presence of fibrosis by histology were obtained from those biopsy specimens. And what Nancy Olivieri noticed was that in patients where fibrosis was observed in the liver biopsies, the liver iron concentration ranged from 8.9 milligrams of iron per gram dry tissue upwards. So she noted that that lower threshold for the observation of fibrosis, that 8.9 milligrams, was very close to the threshold that had been talked about before, 7 milligrams of iron per gram dry tissue for thalassaemia major patients. So it does seem that sickle cell disease patients have a similar liver iron concentration threshold for the onset of fibrosis in the liver. In another study, a later study by Brown and colleagues in the United States, they looked at sickle cell disease children, 27 of them, with a mean age of 11 years. These patients were chelation naive, and they were all negative for HIV, hepatitis B, and hepatitis C viruses. They were all on chronic transfusion therapy, and the mean duration of the transfusion therapy had been about 50 months. and the total volume of transfusions on average was about 17 litres. And again, they were able to measure the liver iron concentration from the biopsy and assess fibrosis from the histology of the biopsy. And on the chart on the left, what you can see is that they found that for these patients, those that had fibrosis had a significantly higher liver iron concentration on average than those with no fibrosis present. So this again supported the general observations of the Olivieri study. They also found that patients showing inflammation in the liver had higher liver iron concentrations than those without inflammation, although that was not statistically significant. Now, furthermore, Brown and colleagues plotted the liver iron concentration that they measured from the biopsies against the total volume of packed red blood cells that had been transfused into the patients. And what's interesting is you can see a nice linear relationship between the liver iron concentration and the total amount of blood transfused into the patients. And I'm going to emphasize here that these were chronically transfused patients, so they were receiving regular blood transfusions, and I'm going to come back to that. But another point that we can see in this graph is that Brown and colleagues colored the data points differently. So the grayed data points, the grayed circles, represent the patients where fibrosis was present. And what we notice is that the first or the lowest liver iron concentration where fibrosis was seen was about 10 milligrams of iron per gram dry weight. That compares very well with the approximately 9 milligrams of iron per gram dry weight observed by Nancy Olivieri. So once again, this is confirming that above approximately 7 milligrams of iron per gram dry weight, which is the bottom dashed line on this graph, once the liver iron concentration gets above that level in sickle cell disease, then there is the risk that liver fibrosis is going to start. Now, let's just go back to the fact that we're seeing this very nice correlation between the total amount of iron transfused and the liver iron concentration in these chronically transfused sickle cell patients. The question is that association always seen? So is liver iron concentration always associated with the number of transfusions received in sickle cell disease? Well, in another study in Lebanon by Inati and colleagues, they looked at the same phenomenon. They measured liver iron concentration in sickle cell patients. In this case, they measured with magnetic resonance imaging. And they plotted the liver iron concentration against the total number of units of blood transfused. And you can see that they do have a correlation. However, the correlation is not as good as that study we saw in the United States, the Brown study. The difference being that Brown and colleagues were studying chronically transfused patients on regular transfusion therapy, whereas in this Lebanese study, there was a mixture of chronically transfused and episodically transfused patients. So interestingly, when Inati and colleagues replotted the data, so they now plotted the liver iron concentration on the vertical axis against the transfusion rate, in other words, the number of units transfused per year for each patient, what they found was that at low transfusion rates, below about 10 units per year, there was not really much increase in liver iron concentration. And the liver iron concentration only started to increase when the transfusion rate was greater than 10 units per year. And then there was a a steady rise. So that's an interesting new observation by Inati and colleagues. And what this implies is that in sickle cell disease, there are spontaneous iron losses of up to about 0.1 milligrams per kilogram of body weight per day. And that could very well be urinary iron excretion, as we discussed earlier in the webinar. We know that in sickle cell disease patients, what's different about them from thalassaemia patients is that they can excrete iron in the urine. And so at below 10 units per year, at rates below that, the urinary iron excretion may be sufficient to prevent iron overload developing. So what is the situation with iron overload and sickle cell disease in Africa? Well, you're probably in a better position to explain this to me. But what I've seen from the literature I've read is that chronic blood transfusion programs, either for prophylaxis against stroke or for other treatment, are not common in Nigeria. And that most children with sickle cell disease in Nigeria receive episodic blood transfusions. And they have the transfusions as needed for the treatment of severe anemia associated with infections, especially malaria. So this was stated by Odunlade and colleagues. And then Diop and Pirenne from Senegal noted that transfusion is mainly used for acute anemic complications in Africa, especially in children who suffer from infections such as malaria. So they reiterate the malaria connection, and also for splenic sequestration and acute hemolysis. Now, in terms of studies of iron status among sickle cell disease children in Nigeria, there have been a few studies. The earliest one I found was from Jaya Kumar in 1987. And she and her colleagues studied children under the age of 10, 24 sickle cell disease children, and they looked at the ratio of iron-free porphyrin to heme in red cells and deduced that there was a high prevalence of iron deficiency in sickle cell patients in Nigeria. Subsequently, Akodo and colleagues looked at 97 sickle cell children under the age of 5 and found that these children had much higher ferritin compared with control children. And they deduced from that that there was likely a higher iron content in the reticular endothelial system. And similarly, Odunlade and colleagues studied 48 sickle cell children and compared them against controls. These children were slightly older, age ranging 1 to 15. And once again, they found higher ferritin in the sickle patients compared with the controls, and looked at the fact that this could indicate excessive iron in the reticuloendothelial system. However, Odunlade and colleagues also noted that the high ferritin could be a false positive in terms of predicting iron overload, because it could be elevated secondary to inflammation. And they noted that liver iron concentration by MRI needed to be used to help answer these questions, which really brings us to what we're going to be talking about in the next webinar, because what we are going to be able to show is that now we have available new technologies that make it much more readily available to measure liver iron concentration using magnetic resonance imaging. So we will be talking about that in the next webinar. But to summarize what we've talked about today, The liver iron concentration can be used to assess total body iron stores. It can be used to identify patients at risk of iron-related morbidity and mortality. It can be used to make better informed decisions on when to start iron chelation therapy, or when to increase or decrease the chelation dose, or perhaps even to cease chelation. And specifically, it can also be used to assess the risk of the presence of liver fibrosis. And importantly, today, we can now measure liver iron concentration non-invasively using magnetic resonance imaging scanners. We no longer need to use invasive biopsy techniques. And with that, I'd like to thank you for your attention today, and thank you for joining the webinar. And just to remind you that there will be a part 2 of this webinar in 2 weeks from now. But I will now hand over to the organizers, Duccio and Baba, in case anybody wants to open up any discussion. So thank you very much, everybody.
Thank you, Tim. Thank you very much. I also wanted to acknowledge Camera. Camera is our partner. I don't know whether she is here on the webinar, but as we come to the second webinar, it is going to become clearer in terms of the collaboration between the different teams. So thank you everybody for participating. And I don't know if there's any urgent question that we would like to address. Otherwise, please do send in questions by mails, mails back to Antonella. Tim, you could see quite a lot of expression of gratitude to your presentation. And I must say that I've listened to a lot of iron metabolism lectures. There's a lot of new things that I learned today. So thank you for excellent presentation. Sometimes it's good to hear a scientist talk rather than a clinician. So he really went down into quite a lot of the details. So I don't know if there is any question. I know we have slightly over. Oh, sorry. Duccio, how many? Did you have 1.5 hours, or was it?
We can still go on. If there is
okay.
Any...
So maybe we would attempt some questions.
Yeah, we just need to consider that Tim is in Australia now, so it is quite late in the night for him.
What time is it for you, Tim?
Don't worry, it's 11 p.m., but don't worry, I've got a strong cup of coffee with me.
Yeah.
Okay, I think we should entertain some questions then. Yeah, it's quite an excellent presentation. And I know you mentioned about the iron in sickle cell disease, some of the reports that you indicated in Nigeria, and also some in Senegal. I don't know if anybody in the platform has some other information about iron overload. And I know, EJ, you did do a paper on blood transfusion or something. Is there anybody that does have some comment to make? I can see people from Tanzania as well. Is there any comment about how common, or do you think it's an unknown quantum? Well, but therefore we need probably some studies to try and understand the pattern. Sorry, EJ, I was asking you a question. Did you do a paper on transfusion? You can unmute yourself and talk.
Good afternoon, Prof. Yes, I did do a paper on transfusion, and very few people actually had the capacity to do even ferritin at that time, which of course we knew wasn't very specific. It's an aqueous phase reactant. And like Odunlade et al. Actually pointed out, the high ferritin levels we're getting, higher than for controls who didn't have sickle cell, may probably, is conceivable that it's because of the inflammation, the chronic inflammatory states that they're in. And then I was one of the authors of the Akodu et al. And yes, we did find high ferritin levels, but we couldn't at that time afford to do a complete study to decide if it was safe to give them iron, because we found some deficiency. quite a few children with deficiency, but generally, because iron studies are quite expensive and not readily available, we have stuck with we shouldn't give them supplemental iron and they should be just fine. So that's more research is definitely needed. I'm very happy to hear that I'm hearing that for the first time, I believe, that the less frequently they are transfused, the easier it is for the body to somehow excrete some and keep a safe balance of iron in the body. That's very good news. Because I didn't know that for sure before, I've always been hesitant. Most of us pediatric hematologists have been hesitant to start chronic transfusion therapy. We would rather do raise hydroxyurea to the highest tolerable dose and all of that. And many of our patients, when they hear all the options, would prefer to start looking for ways to have a transplant. So this is very good news, but we don't have information that is clear-cut with which we can inform changes in practice. So this would be a welcome development.
So,
yes.
thank you. Tim, any comment?
Well, no, I'm very interested to hear the background to the challenges that were faced in Nigeria to carry out these studies, and I do appreciate the difficult decisions that you must have to make in terms of how to move forward. One other question I would have, you've mentioned, EJ, how it's expensive to do some of the iron studies. How about the access to iron chelators? Or can you make any comment on costs or availability, etc., if you were wanting to make decisions on iron chelation?
Yes, that was another reason we tried to avoid chronic transfusion therapy, because only one company, Novartis, provided iron chelators in Nigeria. It was imported. It's expensive, and now with the exchange rates going haywire, I have no clue what it is, but I bet it's through the roof. So chelation is not easy to come by, and we also don't have any standard protocols for giving chelation here in Nigeria.
Thank you. I think that
so it's difficult to come by, yes, and it's expensive.
Okay, Tommy wanted to comment. I don't know whether it's to the same point with EJ. Tommy Omololu.
Yes, that's from last system.
Tommy,
you can go.
Yeah. Greetings, everybody. Thank you, Mr. Tim. That was I joined late, but it was quite a beautiful presentation. Thank you. I'm a consultant radiologist from LASUTH. I would just like to ask, what is the role of the radiologists in all of this? I mean, what are we expected to do, and how do we go about doing this? So, what is our impact in this?
Thank you. Somebody from Canada, is she here? Maybe she's still sleeping.
I'm done. Thank you.
Thank you. So,
okay, Tim, over to you.
Yes. Okay. Thanks, Dr. Tommy. I will be addressing your questions directly in the next webinar. But briefly, what I think you're asking, what is the role of the radiologist? What we are hoping to do is to enable training of radiologists in Nigeria with a technique that is very explicit and that has an easy method of data analysis to generate the liver iron concentration. So in a nutshell, what we have is an MRI protocol that is especially for 1.5 Tesla scanners. And with this protocol, the radiologist will be able to generate a series of images which can be quite simply fed into a software package that automatically generates a liver iron concentration report. So we envisage that the radiologists could become very key people in the management of and monitoring of iron overload in sickle cell patients through close collaboration with pediatricians and hematologists who are looking after the patients. I don't know if what I've said answers your question, but I'm hoping that the next webinar will answer your question in detail.
Okay. Thank you, Mr. Tim. That's fine. Thank you.
Okay, thank you.
What's the name again from Canada?
Uduna.
Uduna, are you here?
I can't see her, Baba.
So Uduna is one of the collaborators of this project, and I think what Tim is highlighting is that the question is really kind of stimulating for next presentation, and maybe one of the key objective outcomes I want to get out of this meeting. So radiologists stay on board, and everybody else stays on board, particularly for the next meeting. Thank you.
There's a question in the chat, Baba, and
Okay,
it is
sorry.
for Tim, asking if there is any physical features indicating iron overload in patients in sickle cell patients.
Physical features.
Physical features.
Yeah. So no. Oh, okay. I mean, to say there is no physical feature of iron overload. Luis, I don't have any feature. Obviously, the major concern is, like Tim said, is the liver involvement, particularly for sickle cell disease, and for cardiac, for thalassaemia, mainly cardiac, but obviously, we're not sure exactly why there's that difference. And when you then talk about ongoing destruction, in terms of liver fibrosis, and therefore issues with liver function, then that is a lead feature. So if you're going to have clinical features as a result of iron overload, then actually you're running into a very lead feature. So for example, if you're affecting some of the endocrine systems, you could have metabolic problems. Again, these are also very lead features. So I would say, generally speaking, you would not really find a physical feature that will give you warning enough to intervene in time to make any significant difference. So any physical feature is a lead feature. Tim, I don't know whether you wanted to say anything, but clinically, I just cannot lay my hands on something that would be a sensitive marker.
Yes, I fully agree, Baba. I think what this is one of the reasons I talked about the elusive iron overload is that it's not obvious from physical features when a patient is iron loaded. It's difficult to tell, and when we do notice, it's often too late. That is when damage has already started. So the objective here is really to try to monitor patients to prevent the liver organ damage starting in the first place.
Okay, that's clear. Thank you, Tim. So, if there are no more questions, only a lot of person saying thank you for the presentation. And yes, indeed, it was excellent. I think we provided something good to the RISE community and to all those who joined the meeting. And so would like to invite everyone to join us again on the 28th of September for the second webinar, which will integrate what we learned today. Tim will be again with us. So I would close the session for today, and thank you again to everyone. Thank you, Tim. Thank you, Baba. Thank you to all
Thank you,
those
Prof.
who attended.
Thank you, Tim. We appreciate the program.
Thank you.
Thank you, Tim.
Bye.
Thank
Thanks
you.
a lot.
Thank you. Bye-bye.
Goodbye.
Thank you.
Goodbye. Goodbye.
Goodbye.
Good night, Tim.